All right, so today we're going to be talking about research in primary care. Again, since we talked about it at lunchtime, we'll keep talking about it. Dr. Hall has graciously agreed to help me with this. It's what, Tuesday? So, yeah. So, we did a good job. So, this to me is always the challenge of residency and medical education on what our purpose is and what we're trying to do. Literally, it's job skills training is most of it. Diagnosing and treating patients is a very defined skill. The problem with our job is we don't know everything we should know within it. And so we have to kind of advance the medical knowledge as we go along. So we need to follow some science, we need to apply some stuff. Everything's not completely figured out, quite like plumbing and those kinds of things. So while we still need our trade that we're working on, we got to go further. And that's really where research comes in, and why research to me in primary care is important, is because there's just so much unknown that we see in our day-to-day. So I got to start out with a story on this one. This is Hardee County, and this is where I had my very first job out of residency. So I was definitely more in trade school in residency. I wanted to know how to take care of people, and that was my objective, and I was going to end up in private practice, and that was what I was going to do. Halfway through my second year, I'd already signed and had a job offer that I was going to take in Moorfield. Has anybody been to Hardee County?
Mm-hmm. Mm-hmm.
All right, so no hospitals, you're way out there. Lots and lots of chicken plants, really, really pretty. You can just drive along the highway in Hardee County and the views look like that. So it's nice, but again, we were way, way out there. So fresh out of residency, 29, moved there, and they were having a cancer cluster. A whole lot of young people in this stretch of the county were coming down with leukemia, brain tumors, leukemia and brain tumors mainly, but it was way out of line with what you would expect anywhere, and people were scared. You got one industry here, and everybody was kind of assuming it's all the chicken plants and all the chicken feces that was causing it. So I show up for this. The state senator at that time was Harold Michael. He was kind of like Robert C. Byrd was for West Virginia as a nation for Hardee County individual. He was head of appropriations, had the big corner office down in Hardee County, and was pretty powerful. Because his constituents were so nervous, he managed to get WVU involved to come down to try to figure out what was going on causing this cancer cluster. So within my first month, I was meeting with occupational med doctors from up in Morgantown to kind of talk about what was going on down here and to start their study. Things went a little crazy at that point. Ended up not staying in Moorfield. Took another job. Ended up coming back all the way over here to Matthias about a year later. Hadn't heard any more about the study, hadn't had any follow-up on what was going on. Come back, and again, within a month or two of me getting there, the study was done, and they were going to have this big announcement at the local, one of the local hotels in the ballroom. The researchers were coming down, and they were going to present what they found to the local community. Anybody got any thoughts on what you would find researching a cancer cluster?
It was probably not a good cluster.
Yeah, it's really borderline impossible to prove one beyond a shadow of a doubt. So it was hard, and it was kind of be negative. And for the most part, that was kind of what they found out. There may have been a slight uptick in estrogen-related tumors in the area, which at the time they also were finding eggs in the testes of the bass. So they kind of thought there could be some estrogen leaking into the system from the chicken farming, but nobody really knew. And so in terms of the cancer cluster, that was where they kind of stopped, but they couldn't find anything why these kids all ended up with cancer. What they did show was an actual decrease in a lot of kinds of cancer in Hardy County, prostate, colorectal in particular. And people weren't dying from that. It was much lower than could be expected. Anybody got just an idea right now why you would have a lower cancer rate, or what those two have in common?
Eating chicken instead of beef.
Nope.
They were dying before they got it.
They were dying from something else before they got it. It had the highest heart disease rate of any county in West Virginia. So those old folk cancers, people weren't reaching the age to get to. So while everybody else was really like bummed out that they couldn't prove the cancer cluster, they couldn't figure out why these kids were getting sick and to work on, I was like, we've got a problem in my community that I've got to help with. You're leading West Virginia in heart disease, you're doing pretty bad in the nation. So I kind of took it on myself that I needed to come up with ways to fix this and get it out to people. I'd started doing a fellowship doctor now at this time, and this is kind of where my research interest started, is I wanted to figure out what was going on with it. Things I didn't know about were like internal review boards and all that kind of stuff and processes. So I knew it was low, so I just started having like focus groups with my patients and bringing them in and asking them questions. If you want to do anything with your data from focus groups, you've got to go through the IRB. So you got to know those processes that I just didn't know existed. We found out people didn't know what their blood pressure was. They just assumed we were taking care of it. They had no ownership or responsibility or anything like that. And how to get out and spread it. So, you know, that's where my interest came from. There was a study in my community, we had a problem, and it found another problem, and I really felt it was kind of up to me to fix it and build on it and everything. And then, like I said, there was just so much institutionalized with research, I couldn't tell anybody what we were finding because I wasn't doing it the right way. And so I've always kind of wanted, you know, between research lunch and this kind of stuff, to teach you guys what the right way is, because when you're out there doing this, you're going to see stuff. We're going to get understandings. When you're seeing, you know, 4,000 visits a year, you're going to see trends for your community and want to figure out what's going on and how you can make an impact on it. All right. So research and our everyday kind of thing. So, you guys seen this? The quadruple aim? Have you seen the triple aim from IHI, what the goal of primary care is? So, we want to improve population health, we want to have satisfied patients, we want to reduce healthcare costs, and to make it the quadruple aim, we want satisfied providers. The triple aim didn't have this one, but I kind of like showing up at work, and I kind of want to continue to like showing up at work, so I always include this. So this is what goes into the medical home model and all those kinds of things that leads us down our path. So what process fits with this closely? This is where the quality improvement comes in, where we want to see where we're doing, see what we're doing better. This is where those, have you guys seen the data from like Quality Blue or the ACO data that they pass around? That's what we're trying to shift to get better care in, but doing it in efficient manners. So, Pdsa Cycle, you guys seen Pdsa Cycles? You've all seen this? This is the quality improvement model. We figure out what we want, see where to change, see what we're going to define as actual improvement, not just where we want to go, but how we're going to get there, and then measure it. So we plan it out, we do something, we see if it works, and then we keep changing it. Pretty simple, straightforward model. Again, all your clinics should and will work on this at some level. And I contrast that back to the scientific method. Mainly I have middle school kids, so I see the scientific method at least once or twice a year for them in their classes, but it kind of always brings me back to what's science and how do we make this? And quality improvement is science to me. Because again, you ask a question, you look through your background research, you come up with a hypothesis on what you think is going to happen, you test it by doing an experiment, you check your data, and then you communicate your results. So a lot of times the only difference between a QI project and anything else is how do you communicate your results. Most of our QI projects, we keep them in-house, and we don't get them out to anybody else. We don't disseminate it, we don't go out and talk about them all the time. There's slowly building up forums for that, but it's not what traditional science has always been. But again, in primary care, what are we doing versus how can we get it out there to everybody else? So, this is a quick one because I was mentioning IRB tripped me up because I was doing focus groups without changing anything. When you do a quality improvement project, you really don't need IRB approval. And you can get it out there as a quality improvement project without this because you're describing what you've done. And a lot of times you're trying to meet a goal that's already established. So we know giving pneumonia shots is effective that way. How do we give more pneumonia shots? Doesn't typically need IRB approval. If you're comparing two methods, half of the patients are going to get this tool to get their pneumonia shot, half the patients are going to get it done in a different manner, then that would go through IRB. And that was guidance from the Department of Health and Human Services, so that came from up there. Some journals may not publish you if you do a QI project, but again, most of what we're doing, it's completely okay and hard to get IRB on every quality improvement measure you're trying to track through and do. Okay. So in terms of primary care research and what we can look at, it's kind of the scope of what we can do goes all over the place. We can go out and we can build our own tools to track the primary care clinic and keep moving them around. We can do our clinical surveys. Again, we can do all the same ones as everybody else. I look at the IRIS study that I'm going to talk about a little bit later where we're looking at diabetic retinopathy. We're tracking the rate of disease in West Virginia in our clinic. So we're actually doing clinical research and everything like that right in Harpers Ferry. A lot of the research projects that you guys are coming up with, these are all the clinical designs and where we can branch out. These don't have to be done, by the gastroenterologist, by chronic pain management anesthesiologist. A lot of these are primary care problems, and we're the ones that know them the best. And again, other things that you can study and look at. So health service studies, informatics, how well are we uptaking with our new EMR? What tools work better? People have studied like the health maintenance tabs and stuff like that, and what their impact is on reducing or improving immunization rates. Team development. Did you guys know what team you're on? Gold. Who's on blue team? Me? Yeah. So people look at that and come up with better ideas on how to get our team developments going on. Then again, health system studies. Dr. Hodder, who runs the Ctsi, has been talking about looking at what the effects of the ACA is in West Virginia. What are the benefits and what do they mean to our patients? Again, that's looking at it from a primary care lens. And then again, educational studies. When we're coming up with teaching techniques, are you going out there and writing them down? Are you studying them? Precepting, which is such a one-on-one kind of interaction, is right for literature on it. Especially if you're precepting as a community physician. So if you have med students or residents come in away, getting that down definitely helps. So kind of why we need to talk about this and why primary care docs looking at research is important comes down to who's sick and who are they seeing and where our impact is in the community as a whole. So none of you can read the slide from that distance, can you? Okay. This breaks down who's utilizing the healthcare service for 1,000 people. So we start with 1,000, which is the blue guys here. In a given month, 800 people will have some kind of symptoms out of 1,000 in the U.S. 300 will think about seeking medical care. 200 will go to a doctor. And of that, over half of them are going to primary care offices. So again, out here, going into community access is here. As you go down, go to a hospital clinic. It's only 21 people. Go to an emergency room. It's 13 people. Get admitted to a hospital. It's 8 out of 1,000. Get admitted to an academic medical center. It's less than 1 in 1,000 every month out of all those people. All the studies, or the vast majority of the studies and the understanding that we have in medicine comes from these academic medical centers. That's where the research is taking place. So, we're up here at over 100 and they're less than 1%. So, 100 to 1,000 times more people are seeing us. So you're missing out on a lot of what's going on. The research is on the sickest of the sick a lot of times, or the people who live, in Rochester, Minnesota, or Baltimore, and stuff like that. You're not always getting the best subset in these research studies. But because we're out there thinking about things, seeing things, we're this big connector. We're breaking it out into the communities, kind of away from the academic side of things. So we start talking about community engaged research, and that's kind of bringing us back in and bringing our communities back in. And that's where I want you to think about this and where we impact it. So it's just more of a framework with things that we're going out and we're getting input from the people who are actually using the stuff. It's not all the academic researchers. We're going to talk about more later about kind of the networks that build this up a little bit and how to do it. But these things, you're working in concert. So much of the time you have somebody sitting up in their office who's not out there coming up with the idea and then using the best science they have to see if it's going to work. This model in getting your community involved means you're going out and talking to people. So a lot of times what will happen and what we're trying to do, and if you're with us long enough, you may talk with researchers on different studies. They come to us and want to talk to us about what our thoughts and what our plans are to build a better study, to build a better tool. You talked to, on the suicide prevention survey, didn't you? So that researcher from Morgantown came down. What was she asking you about?
She was asking me about whether or not I'm screening for suicide at my clinic visits, things like that.
Right. And she ran through the tool with you and asked kind of your opinion on how practical it was and everything like that. The name of the tool that she wanted to get implemented was called an ASQ, something suicide questionnaire. So my first comment was, that's probably about as bad of a name for a suicide screening tool at a primary care office as you could come up with, because we already have an ASQ. It's for babies.
Yeah.
That's not what we're gonna think about when we do this. So again, it's shifting what the goal is. Somebody who's not working in the field or not working directly with the communities isn't getting that perspective. And likewise, it's taking it out and not just building it with primary care doctors, but into the communities themselves and kind of reviewing the project before you completely submit it and trying to get those researchers to do that. Like I said, we'll talk about this later, but again, as primary care doctors, we can have a big impact being the community for people as opposed to being completely the researcher ourselves. We can help shape and build better projects and get people to recognize what's going on the ground to begin with. And this just says, traditional research has not really solved healthcare disparities. And so that's kind of why they want the communities involved and get their opinions on everything. And again, that makes sense. If traditional research methods could solve all of our healthcare problems, the system would probably work a little bit more functionally than it does now. All right, so this is more just to have in here to go down through a difference between what a community gauged and a traditional one is. The one thing that stands out to me, a couple of things. Again, even if tools are made, we're trying to adapt them to what fits the population. So sometimes we even change the terminology and stuff in the tools when they're going with it. This is the big one. This results being reviewed in the community. That very first project that I started out, they came down asking my opinion on, I was really impressed that they came back to Hardy County to tell the people of Hardy County what was going on. And it wasn't, you know, the ballroom at the South Branch Inn was packed. Everybody was there. They wanted to know what was happening, what was going on with their community. It was, every doctor in town was there. And, you know, so that was 8 of us. And then there were probably 100 other people from the county and the community in there to hear what was going on. And like I said, that was really powerful and it made a big difference to me in how the study was received. Like, I don't know what, I've never bothered to look it up to see what the impact was off of that study, kind of nationally, even if they got a publication or anything from it, where it was, but it really changed my practice. And so it's kind of important to me, anything we do, we get out there and tell the people who we're doing it with what happened.
One of the points I want to make on this is the reason why he's bringing up community engaged research compared to our traditional like gold standard randomized control with the tertiary care facilities is because when you engage your community, which is kind of like at the core of family medicine, you know, we're not just getting the opinions of the community, they're more leaders than the PIs are. Because they're addressing the community's concerns and they are the voice, whether it be, you know, the local coal miner or the person who works at 7-Eleven down the street. They notice what's important for their area. When those results, when it goes to dissemination, rather than this traditional method where the scientists in the ivory tower at the big city are just doing their science and publishing it, what about some, you know, community far, far away? Those people don't care. You know, they're like, oh, nice. Did you see this article written about us? If it even gets to that. Whereas if it's community engaged, the results are disseminated both to the scientific community and to the people who contributed to it. And so then that can promote further change. So that's kind of what the point of practice-based research is.
I always enjoy the use of ivory tower when I think of Morgantown as our kind of academic center. And health sciences is the ivory tower that's, you know, 80 years old and probably more the asbestos tower than the ivory tower.
They're working on it.
Yeah, they're working on it. They keep remodeling it. But boy, you get in those upper floors and it gets a little, I can't believe they got patients in there. So, again, this comes into back to where we can fit in. So there's a higher level of research than just the regular clinician participating in research. And we happen to have one of our residents who's been working at that and knows it better than I do. So I'm gonna let Dr. Hall talk.
Yeah.
Specifically for a moment.
So I know most of you guys know that prior to coming here, I was working on a master's. It's through WVU. It's the Clinical and Translational Sciences Institute, Ctsi. It's a master's in science, and what does it mean? For a lot of people, it means nothing. And for others in that small community that we have at WVU, and then select places around the country who also offer this degree program, it means a lot more. And applying to it, I had no idea what it was. But then after, a couple months of being in the program, you realize, oh, I kind of enjoyed stuff like this all along. I just didn't know there was a name for it. And so what it really entails is taking or being mindful of both, what clinical researchers do, say at the PhD level of, a cardiovascular scientist who studies rats after making them genetically susceptible to develop coronary artery disease. How he then takes that research and publishes it and says, well, we exposed them to this, 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 and this, and they had a whatever percentage increased likelihood of developing this disease. That is kind of where it all starts for then how can we make guidelines for humans to take statins and beta blockers and all the other medicines, things that we do to decrease their risk. That's all well and good, but then we learn this in med school, and then you go out and play doctor, and you really don't know if you're promoting change or doing the due diligence to your patient to improve their quality of life. So what this master's does, or what Ctsi really kind of the program teaches you, is how to take that playing doctor bit and doing the guidelines, but then reversing it and saying, well, was the evidence-based medicine or these practical guidelines, is it really working? And so some of the numbers, I think that, I'm a numbers guy, so I think the numbers that help me best is that only 25% of what we practice is evidence-based medicine. It's kind of scary if you think about it. So that means 3/4 of what you do is kind of just the art of medicine. And you think about how many journals are out there and how many publications are made, and we're still only 25% evidence-based.
We went over 1 million per year in 2013, I think it was. That we
Yeah.
started 1 million articles a year.
And it's only getting worse. And by worse, I mean the number is increasing, which it's flooding the scientific market of articles, and it's almost decreased the, validity of getting published anymore.
Yeah.
Side note, but, having said that, it's rather tough to really know if, am I doing the right thing? One of the other numbers that I really like, and maybe it'll stick with you, is that for 41% of the research projects that make it to like that stage 3, stage 4 level of, clinical research, it takes 17 years for that to be implemented into clinical guidelines. 17 years. So this stuff is just kind of like sitting on the shelves. So the answers that are out there that could help your patient in clinic tomorrow, that the answer is sitting on the shelf since yesterday and has been published, it takes 17 years for it to go through policy, for it to, make change. And that's the other aspect of what Ctsi teaches you, is it's not just the science, it's not just the numbers, it's the economy. It's the disparities that you have to fight through and dig your way out of that everyone in this country is facing. So that's kind of like the preface that a lot of people don't know exists, that you will face as a researcher or a clinical researcher. So, after saying that, you say, well, then why do I want to be one? That sounds like a lot of work. It is. And granted, I don't have that MS after my name yet, but you don't have to have an MS to be a clinical researcher by any means. But you, I would say, have to want to have that drive to make change, or to let others know that, hey, this is something that I found, whether it's in little old Jefferson County. I don't really know if I could answer why I'd be a clinical researcher. I never thought that I would go into a master's program by any means. But then after starting it, I kind of liked it. You find your own niche, whether it be in urgent care, or whether it be in OB or geriatrics. You'll find something that you really want to do and that you really want to focus on, and maybe report back to the people in that ivory tower. So it kind of goes to like what degrees are available to help you.
I'll get there why I want
Yeah.
clinical researchers. I want somebody in the ivory tower who knows something to begin with what we're facing, what the design problem is, who has some understanding of what's going on out there. And we need everybody on the research team. We need the statisticians.
Yes.
I'm going to talk about just being a clinician in research in just a second. And it's, we have to collaborate. But the more understanding you have with one individual that can bridge those gaps and bridge in between, and you have somebody who's trained and has got the right credentials to get through those doors, to get those NIH grants, to get the money to do research studies. We need people like that. So we need people who are going out and getting to that. And that's what we hear on the CTSI level, is how you build up this repository of clinicians who want to do this, who have the skills to reach out and do this, because they're the ones who know. And it's getting these, getting the degrees, the MPH or the Masters in Clinical and Translational.
So what he's talking about is kind of like what we call navigators. And it's the navigators who, I should preface by, I guess, saying that most people think that the doc is going to be the team leader. That's not always the case when we're talking about practice-based research. They might be the principal investigator. They're the ones who are, providing medical care and reporting back and saying, hey, I found this. But the navigator is really that person, and that's why the CTSI is great, because they have separate little departments within the CTSI that know exactly who to connect you with. That you didn't even know these people existed, whether they be community leaders, statisticians, outreach or focus groups, and these are the ones who kind of bridge that gap. And it's kind of what leads to what my working in my degree is, this translational component. It's all about bridging that gap, because there is this huge gap between what happens at the bench and then what happens at the bedside. Okay? Historically, we don't communicate with the scientists, and they don't really communicate with us. They put out their papers and they did their job, because normally they are working on a publish or perish kind of model, whereas we're working on just hurrying up and seeing the next patient. So this clinical and translational science component is being able to kind of act as the interpreter, if you will, and having that experience to read an article and say, okay, this is great, yeah, these are the numbers, and I understand them, but what can I do with them? And so that kind of goes to the what degrees. Yeah, it's nice that if you have an extra degree, but I joked with Dr. Lewis because sometimes I think the ones who best navigate through translational research and practice-based research are the people who have MPHs, because that's kind of what their degree program facilitates. It's only until, like early 2000s that these Ctsi networks were started, and they put a separate name to it, and focused more on the translational research component rather than just like the public health. So sure, it helps to have the, MD and DO. In addition, to this, because we get that public health from med school, whereas maybe, others, like say if they were bachelors or masters of other fine arts or whatnot, may not get. In my opinion, I really don't think it truly matters what degree you have in order to work in a practice-based research network. But and I say that because those who have different degrees all bring a separate kind of component that helps that project.
Yeah.
So, what can this do for your career? I don't know the answer to that yet, because I'm still so obviously early in the game, and I have yet to finish it. 2 classes to go. But someone like Dr. Lewis could really explain that to you. If you met some of my classmates, colleagues that I had from that program, one really good buddy of mine who's now a resident, he was MD, PhD. And in his spare time, in the last year, or maybe he's a 4th year med student, but he's finished his PhD. Yeah, he's a 4th year med student. I'm a 2nd year. I lied, he's an intern. So he's a 1st year resident. So he has his MD and his PhD. In his spare time on his last year of his PhD, he decided, you know what, I really like this stuff. So he got his master's as well.
Is he married?
Yes, and has a kid. And I believe he's in neurosurgery. And the most normal human being actually that you'd ever meet, I know. Over and above all that, honestly, he was so enthusiastic and loved every bit of the true science down to the numbers, to like the, public health and even like social disparities part that comes with clinical research. And he had already been published multiple times, and he would say, you wouldn't even imagine that I think this master's has done more than his PhD in neuroscience at that time in his career, because he was able to directly correlate his neuroscience PhD and how he wanted to implement that when he becomes a neurosurgeon. And he will be able to have those ideas and those skills in his toolbox to make that transition, and he really would be like the true maven that Ctsi kind of promotes.
Right. And this builds into an academic career. And if you have interest in academic medicine, that's one place I think is really good.
Absolutely.
It gets your foot in your door, gives you a skill set that they need and are lacking, and lets you build up from there. So to me, that's where it gets you in. But like I said, this gets you, the training and everything gets your foot in the door for those grant monies and NIH and all that kind of stuff. So that's where you can take these. Just as a clinician, so this is what, most of us aren't going to get the master's like George. And I thought about it, but if I lived in Morgantown and didn't have kids, or didn't have teenagers in particularly, I might think about going through everything, but where I'm at, it's really hard to go through all that. And so when I got put in this co-director position for the West Virginia Primary Care-Based Research Network, I was like, I'm not a researcher, I'm just a clinician. And I was feeling kind of overwhelmed by all this because I don't have all this training. I don't know my stats cold. I don't know my research design cold. I've never had any formal training in it. I've just kind of figured it out for each and every instance that I need it and remember a little bit and forget a lot more. But keep building that up. But I went to the National PBRN meeting and met another director and from another one who's been doing this for 20 years. And she told me, oh, you don't need to know all that kind of stuff. People get their PhDs in that kind of stuff. People go get their masters. You're a clinician. Just work with people. Network and collaborate and let them use their expertise. You don't have to know how to do everything, which is kind of an odd thing to hear as a family doctor, because we like to know a little bit about everything. It's in our ADHD nature that we like to jump around and but that was her big point, is work with the actual researchers. They need you as much as you need them. The other things we can do is when you have that great QI project, get out there and talk about it. Put a poster together, go to your state conference, talk to other people, get what you're doing out there. And likewise, when people are doing those poster days at the state meeting, go through and talk to them, talk to the residents. Even if you've been out in practice for 20 years, what they're trying, you might be able to take back. You gave their research more impact that way. Learn that, learn what people are doing at the roots. And so, you know, I'm going backwards, but you know, your expertise is important. When you get a survey to fill out for a researcher, I mean, you fill them all out? Sometimes they give you $5 and you feel guilty and you might fill it out, otherwise, oh. But they need us and they need our opinions. And so just even taking the time to fill that out is good. I appreciated Wayne and Maddie, and did anybody else talk to them on the suicide screening? I know you guys did, but I appreciated that a researcher had questions and 2 of our residents reached out and agreed and talked to them. And so as those things come out, you know, I'll send the emails, I'll make sure you guys get them. But, you know, taking that little bit of time to explain to somebody what it's like for us and what it's like in clinic, in the hospital, in our rural communities is important. So when you have the chance to do it, just take it. And we can get just highly involved just doing that, just being an expert, just an expert in what we do, you know. Whenever, you know, we're an expert in everything, but running clinics. All right, so PBRNs, you've heard me talk about it. All right, you've heard me say PBRN, it's a practice-based research network. This is the other way we can really all get in, contribute, and get connected. So does anybody know what a practice-based research network is? Did anybody know you're all part of a practice-based research network?
Yes.
Good job. So basically, and this is the government definition of them, these are run through AHRQ or ARC, which is the
It's Division of Health and Human Resources.
Yeah, Health and Human Resources. But they're groups of primary care clinicians and practices who work together to answer community-based healthcare questions. And then we translate those findings into practice. So, you know, the West Virginia PBR that I'm going to talk about is clinics all across the state. So it's groups that it can be 10, it's probably the smallest one I've seen, to hundreds of practices coming together to work on single questions. And where that helps is you need an N. You have to have power, your studies mean more. If you submit something and they've got 40 people, well, how does that translate to the rest of the nation? If you submit something and 40 clinics have gotten 40 people, suddenly you've got a lot more oomph behind it. You've got something that's more power, something that means more. What it's also become over time is helping clinicians really engage in the quality improvement activities. Because going back, a lot of primary care research is quality improvement, but you do quality improvement at 40, 70 sites, you're doing real research and you're making potentially huge impacts. Anything on PVRs? Okay. So the West Virginia PVRI, and this is the one I'm the co-director of, is spread all across the state. So we've got 18 healthcare systems. Most of the family med residencies are involved across the state. Most, not all, of the federally qualified health centers are involved. We've got a few practices that aren't directly tied to those, but got a big network, lots of people covering all of West Virginia. This is through the West Virginia Ctsi, Clinical Translational Science Institute. Their goal is really to make healthcare in West Virginia better through research. So I sit on the steering committee for that, and every month or every quarter, we get listings of where West Virginia ranks nationally in several health markers, just so we keep an eye on where we're at and what we're doing, and what the purpose of our research studies are, is to get our state healthier. Anybody know where we're at? Just generally in health rankings. What? Yeah. We used to say, thank goodness for Mississippi. It doesn't look like we can say that anymore. So it's just us. We were 50th in a bunch of these rankings, but there's a state group that's working to that. And in the group, it's not just WVU. It's not the WVU Clinical and Translational Science Institute. It's WVU, it's Marshall, it's WVU SOM, it's CAMC, the VA's in it, and NIOSH, which is the National Institute of Occupational Safety and Health, that's got a big outfit in Morgantown in West Virginia. So all the major hospital systems, educational and research centers in the state work together to try to solve these problems and make West Virginia healthier. It used to be we were all beating, WVU didn't collaborate with Marshall, or it was hard. But now, because they've got this built out an NIH grant that we even still keep funding, even in the current climate, we're building up. So the areas that we try to research and improve West Virginia's health on in particular: addiction, cancer, cardiovascular diseases, chronic lung disease, and neurological diseases. To get spread across West Virginia, these were picked. One, they're problems in the state. Two, these are areas that we had experts in to really build up, and people who know what they're talking about, and a lot of support for. We've got the big Neurosciences Institute up in Morgantown. NIOSH does tons of work with chronic lung disease and everything. Because when you look at these, does anything stand out to you? Because one omission stands out to me.
Diabetes.
Yeah, metabolic health and everything like that. When we have our practice-based research meeting every year, where we get clinicians and researchers all together, the two topics that come up that we should be studying and try to make the impact are, diabetes and addiction. It was chronic pain and now addiction. So opiates and how you do them, but an interesting switch from it's just more chronic or more addiction now than chronic pain. Diabetes we tie back in, we still study it, but we do it more through cardiovascular diseases. We've got to build up the infrastructure to study diabetes specifically, and I think we're getting that way. But that's why those are the specifics that we kind of study.
One of the things to point out is, if you're interested in clinical research, if you're interested in working with and doing practice-based research within the CTSI. Obviously, they would love for you to focus on one of these topics.
Yeah.
That being said, they have, at least when I was there, they were constantly sending out, hey, if you have a research project and you want to submit an IRB and a proposal, we'd love it because we have money available.
Maddie got one as a third year.
Yeah.
So she submitted or you guys all did. Don't need
She
to-
did all the great writing.
Okay. Maddie was the one who brought me the grant to
Yeah.
critique, so I just throw Maddie out there first. But your pilot grant, so I mean, $2,500 if I'm correct.
Yeah, something's down.
Yeah. But that's how she's now able to give talks and buy lunch and keep that lecture series going on Fridays for the staff to teach them about diet and education as part of her project, or part of your all's project, and really build it up. So these grants are available, these little pilot funds. The bigger one, and we'll talk about in a minute, is the iris scanner that we have. Dr. Klein and I worked to get the grant for that, and that was a $50,000 pilot grant that we ended up using to purchase the iris scanner so that we could then start screening our patients for diabetic retinopathy. And that's part of a bigger one. But within the network that we all participate in and have, we're getting grants and projects. And Rosie has done one on, too. She didn't apply for a grant, but she got help support in study design through the project, PBRN. And again, if you guys have any ones that you feel like you need a little bit more help and support with, we can get you to talk, your research idea, your posters, we can talk to the people, and we can talk to Stacy and some of the other folks in the PBRN and get you connected with researchers to make your studies better, even if you're not taking it to other sites. So you can build it up and get it better that way. And like I said, we've got a few coming out of our clinic that way that were our ideas and are reaching into the bigger network to make better.
And as an incentive for those who are interested in academic medicine or holding a faculty position somewhere, you can put those was awarded this kind of grant, you know.
Yeah, that goes on your P&T file.
Yeah.
P&T is promotion and tenure. So once you have an academic position, to move up from assistant professor to associate professor to full professor, you need to show your work in teaching, service, and scholarship. So under scholarship, the grants go in to build up your case that way. They also look for publications. So to go up from assistant professor to associate professor, which you would, if you work for us, you would start as assistant professor usually. You need 3 publications within 5 years to kind of move up. And so that's where these kind of tie back in, if you're in an academic role, what that matters for. And it doesn't have to be full research studies. I made it to associate professor doing, review articles and stuff like that before I got involved.
And we're not talking like the RO1s or anything like that. Like
No.
that, yeah.
No,
Right.
an AFP article.
Right.
Something online on FMDRL counted when I was there, or MedEd Portal's the other one that those things count. So those all build up. But just 2 projects, and this is more so you guys know what's available and what we do and what practice-based research looks like. You all know we have an iris scanner, right?
Yeah.
Do we get our diabetics there? Yeah,
Try to.
that one.
Try to.
So there was a need for diabetic eye care across the state. You get out into other parts of the state and, it might be 25 miles to an ophthalmologist, but it might take you 2 hours to get those 25 miles just on the lay of the land and everything like that. And people weren't getting there. So the Eye Institute and IRIS partnered with our network. They picked the right, us included, to get iris scanners. John and I wrote the grant through the CTSI. The other sites got funded by a few private corporations. And then we went out and we started screening people. Screened almost 700 people for retinopathy. You know, we found over 480 cases of eye disease in people who weren't getting screened at that point. 17% of people actually had diabetic retinopathy in our screenings. This one, the survey tool is not perfect, but I'll throw this one out there. That's lower than the national average. So to me, this goes back to what was our problem with the cancer screenings in Hardy County, or the cancer rates. Well, people are dying from something else before they get a chance to get retinopathy. So our diabetics are probably, again, still and smoking, not walking. We don't even have to go into eating right because we know that one. But we were able to take this data and go to insurers and show them what we were doing and show how having a retinal scan device in your clinic worked. And now Medicaid's paying for it because of this, EIA's paying for it, and Highmark Blue Cross Blue Shield's paying for it. And we're petitioning with Medicare to pay for the service out here. So, you know, those iris scans we're kind of doing are actually changing healthcare policy. And that scanner we have in our clinic, I mean, changing Highmark's payment pattern is a big deal, you know, hard. And so the networks work with that. Our clinic, all of us have had in some way a shape in building it. The ECHO project is out there. This is another really kind of cool one. This came from Cabin Creek Health System, which is an FQHC in more of the southern part of the state. Got a grant. An ECHO project is you have a group of experts, 3 or 4 specialists, who primary care docs present patients to. And it's hooked up on Zoom, which is kind of like Skype, and it's a video conference every other week. And the primary care doc will present their patient. The first one was on hepatitis C. With Harvani, how do you treat it? No primary care docs. We weren't trained. We didn't have it when I went through. What do you need to do? So they built this up so we could start getting people out in the communities doing it. Because again, it's a long way to Charleston or Clarksburg or Morgantown where we have GI docs or ID docs. And it's prescribing medication. We can prescribe medication, we just need to know the side effects. So this weekly conference hub, and 13 different clinic sites were participating with it. You know, the first year 45 patients got presented and then treated. So this actually built up that people were getting treated out in these FQHCs across the state. Since then, they've added chronic pain, MAT, psychiatry, and chronic lung disease ones. We've got access to these. Some of them are on Thursday afternoons. Other ones are on, or Thursdays at lunches and Tuesday afternoons. I've sent out a few notices, but these are out there. And these are just a great tool for the rural practitioner, somebody out in the way who's not right in the midst of training, where you can learn a new skill, where you can have resources, where you can get your difficult, concerning patients presented and get some help. I mean, just to be able to present your difficult psych patients when you don't have a psychiatrist for, yeah. I mean, when I was in Matthias, it was an hour to Winchester, an hour to Harrisonburg, Virginia, an hour to Petersburg. And so when we had psych problems, we had to figure it out. Or lots of things we had to figure out. And just to be able to throw it out there to have some expertise would have been really reassuring back then. So these are the kinds of things we build up on the bigger scale. Like I said, we can do smaller pilot projects. There's always funding and everything. Anybody got any questions about kind of where and what we can fit in with research in primary care? Good.